Good morning, everyone. We'll just give it a few more minutes.
Good morning, everybody. JPO Maiden here. So I think we can go ahead and start. I see Dr. Sanson is here already as well. So I guess Henry is going to start today. Perfect, Henry. So let's go ahead.
Yep, perfect.
Your co-host.
Thank you. Yes, let me share my screen. Okay. Can you see my screen?
Yes, Henry.
Thank you very much. Good morning, everyone. Thank you for joining this morning and the opportunity to present this morning to you as well. Today, as Dr. Almeida mentioned before, we are presenting two pituitary cases and hope that you enjoy the presentation and the discussion. So first, we want to thank everybody in this team that has been working and providing us with input about the important aspect of this case. We have been discussing about this neurosurgery, ENT, neuroradiology, pathology, endocrinology, ophthalmology. Thank you, everyone. Dr. Schollis, endocrine fellow, is going to be presenting as well with me this morning. And I'm going to let her discuss the case.
So this is a 67-year-old male who said that over the last 2 months, he essentially went off the cliff with his health. He lost about 35 pounds of weight in the last 6 weeks. I was having significant fatigue, nausea, and he was having a lot of difficulty with complex cognitive tasks and poor word finding abilities, poor short-term memory, and he had decreased libido as well. He had been on and off of testosterone replacement during a 2-year time span. So that's just something else to note as well. On his physical exam, it looked like he had some decreased pigmentation, some fine lines around like the eyes, but no acanthosis, no striae on the abdomen, and no ecchymoses, myxedema, or acne or hirsutism. And there was no like Cushingoid facies with like more plethora around the face or hyperpigmentation. There was some superior temporal right greater than left eyelid drooping and like loss as well, visual field loss. He had no dorsocervical fat pad and had some mild adiposity to the breast tissue and some mild adiposity to the abdomen as well, but otherwise nothing else that was that significant. His labs were interesting because he had a prolactin of 206. His cortisol level, though, was 2.4, so it's pretty low, and this was done within the morning time. His FSH and LH were low for the testosterone level that he had. So if we were thinking that this was primary hypogonadism, so something wrong with the testicles, we would expect that the LH or the FSH would be elevated. But for him, they were low, so it points to something. Obviously, we're in pituitary conference, so it's related to the pituitary. And the testosterone was very low. His TSH was also low as well, and his free T4, which wasn't highlighted here, but it was low as well. So he has secondary hypothyroidism, secondary adrenal insufficiency. He had secondary hypogonadism as well. His IGF-1 was still okay. It was 159, but the question is, could this be acromegaly as well? But I don't think so based off of this level. But that's still something that was looked into. And his sodium level was 137, so he doesn't have a loss of his posterior pituitary function. And then the prolactin is elevated. So thought is that this is possibly prolactin secreting adenoma.
Thank you very much, Dr. Scholes. So this is the MRI that the patient had in an outside institution. As you can appreciate, here there is a good size lesion that is bright into one with contrast and some soft tissue here on the top that you can appreciate in the coronal and sagittal. So the first thought was that with all these symptoms that were relatively sudden, the patient developed apoplexy. We are seeing an apoplexic lesion, apoplexia. And then he was evaluated by endocrinology and also by ophthalmology. And I don't know if Dr. Pless can comment a little if he's here.
Hi, good morning, everyone. Yes, I'm here. The patient had very mild visual field defect in the right eye, which was non-specific, not correlated with any loss of the retinal nerve fiber layer. His afferent function was normal. His efferent examination was also normal. And structurally, we didn't find anything that would suggest ongoing or previous optic nerve compression. So even though there's contact between the dome of the mass lesion and the chiasm, there is no real conflict. So some of these things can sometimes be chronic, compressive, but not show retinal nerve fiber layer loss for some time. The optical coherence tomography, which you're showing here, shows the segmentation of the retinal nerve fiber layer. The top layer on the retinal cross section is the retinal nerve fiber layer. Just below it is the ganglion cell layer. And we can actually measure both and get a very, very good, very accurate thickness measurement of the, and that correlates very well with visual field defects and with afferent function. So this patient didn't have anything substantial to suggest that, that this contact is causing loss of axons.
Thank you so much, Dr. Pless. I appreciate your comments a lot. Okay, so the patient then was evaluated by neurosurgery. We're seeing a patient with a pituitary lesion, tumor, probably prolactinoma, plus apoplexy. He was having symptoms, as Dr. Schultz mentioned before, but not visual problems or compression in the chiasm, no CSF leaks. Also was evaluated by ENT, no leaks were found. And so neurosurgery recommended follow-up at this point. And then the patient came back in February. And we can appreciate here 2 columns. This one here from October and this one here from February. So in these T2, we can see the lesion, and the cystic lesion was dark in T2 and was bright in T1, regardless the use of contrast. We can appreciate here the lesion without contrast, the scans without contrast, and here the scans with contrast, as we can appreciate here, the enhancement in the cavernous sinus. Something that we can see is that this component here remained almost the same, and there was a decrease in the soft tissue that was present on the top of this cystic component. There was a minimal enhancement here, probably related to the infundibulum, some pituitary on the right. It was compressed by the cystic lesion. And I don't know if I'm missing something, Dr. Vibutia, you would like to add something at this point or in the next slide with the CNS?
Yeah, go back. Good morning, guys. This slide is very interesting slide. It very correlates with the clinical presentation. If you look at the October 2021 exam, what we see is a lesion in the sella, obviously, and it's very dark on T2 and has a sliver of bright signal along the superolateral aspect on the right side. And if you look really carefully and closely, you can see a rounded structure within it itself. But most of the lesion on T1 is intrinsically bright. So whenever we see bright thing on T1 before contrast and it's dark on T2, there are 2 possibilities one should consider. One is hemorrhage, the other one is proteinaceous material. So this is too dark for protein, but protein can become dark as it becomes desiccated and dehydrated. But with the history, abrupt onset of history of symptoms, this is definitely, a sequela of hemorrhage. And what is interesting to me was that if you look at the gland here, which is on the top of the, I don't know whether I can use the pointer here or not, but if you look at the middle, the T1 weighted sequence, you can see a soft tissue just above the cystic area, which is hyperintense in the midline. Yeah, so you see that just below the chiasm, you see that dome-shaped structure, which is hypo or isointense to the brain signal. And if you look at the post-contrast, just the bottom panel, you can see that, as Henry pointed out, only a small fragment of it is enhancing. And it clearly tells you that this is an infarcted gland or residual tumor, whatever you want to call it. So it really correlates well with the clinical presentation of pan-hypopit. And as you can see in subsequent exam in February, that entire tissue has completely dissolved. It's completely atrophic, and it fits with the MR finding of lack of enhancement. And what you now see is just a cyst, a hemorrhagic cyst, which has no residual lesion left around it. You can see there is no enhancement around it. And it's a very thin wall, hemorrhagic containing lesion, which has also shrunken compared to the previous exam. So this is basically a residual sequela of apoplexy with complete infarct of the gland and solid tissue. Thanks.
And Prasanna, before you leave, I'm just going to ask a couple of quick questions, just because it's just sort of rich on teaching and also learning, and also for Dr. Sampson, as we're looking more and more at these, lesions. Normally, when I was training as a resident at a place, I did a lot of pituitaries. Dr. Wilson, right? He's just like Dr. Lowe's and Dr. Roth, and there were some of the giants doing a lot of these pituitary lesions. We used to think that apoplexy, you didn't operate unless there was a problem with vision and stuff like that. But you illustrate the sort of the gland, right here. Let me see if I can draw. I've been learning from JP how to use these tools, but you can see the gland is fat right here, and yet the gland is now very, as you said, very thin right here. But there's this little bright spot that seems to be right there. Can you comment on those? Just elaborate a little bit more, and then I'm going to ask Dr. Sampson to to just educate us as to what we think happens to the gland in between these two episodes.
The bright spot, what we are seeing is that it's hard to say, but most likely from my experience, the bright spot is just a compressed infundibulum. And my experience has been even the pituitary infarcts, the infundibulum typically will preserve the blood flow because there's dual blood flow and it will enhance. It may get thin, but it will enhance, continue to enhance irrespective of what's happened to the gland. So if you look at this now, if you look at the February exam, the post-contrast, you can see the infundibulum is straight in the midline more or less, and it's enhancing. So and at the bottom of the infundibulum, you can see a subtle, if you can appreciate, there is some enhancement of the infundibulum as it inserts into the gland. And if you can imagine now that if you just compress it, it'll look like a solid dot or a ball. If you compress it, if you push it up, it will look like what we see on the October exam. So my hunch is that that's the infundibulum which is enhancing.
That's what I think as well. Dr. Sampson, thoughts about, what we're seeing right here is the gland heavily responds to this pressure all of a sudden. And then, like I said, traditionally we had thought about, we just give it time, to relax, and depending what happens, you may not need to do emergency surgery. But I would imagine that this pressure changes, this thickening of the gland, and suddenly this sort of like thinning again reflects some sort of atrophy in the gland. What are your thoughts about this? I guess I'm alluding to, should we be doing this surgery sooner rather than later, even if there are no vision changes type of situation?
It's an excellent question. And the pituitary itself has a blood flow of 12 milliliters per minute. It needs that, and it needs the trophic factors from the hypothalamus to continue to keep it healthy. So when the stalk and when the gland are compressed and you do not have those signals to feed the pituitary from the hypothalamus, and you are disrupting blood flow over time, you start to see that atrophy or that death of the gland. Now, mind you, in this particular gentleman's case in October, he was already hypopit with regard to cortisol. He needed cortisol. I think his cortisol level was 1 to 2. He had secondary hypothyroidism. He also had hypogonadism, but that could have been the prolactin. He still had preserved growth hormone, but we're going to have to see where he's at now post-operatively over time. So I don't know that earlier surgery would have preserved a lot of pituitary function because it had already been quite devastated. And in my experience, what you have pre-op, for the most part, you have post-op. So I don't see a lot of recovery of the axes after that damage has been done.
And that was going to be my next question. Do we know, as to that aspect of the recovery, I guess, anecdotally, as you say in your experience? I think this is potentially something that we can look at here, Susan, with all the three sites, all the apoplexis, and testing that question. Doesn't matter how fast after the apoplexy, even if you lost all your hormones, is it dependent on age? Do you get some return of some of the hormones, yes or not? I bet you we have a good, healthy number between the three sites to potentially ask that hypothesis, testing it that maybe if we do the surgery sooner rather than later, irregardless of the vision changes, it may lead to the return of some hormonal function. That can be the null hypothesis, but something for us to consider, obviously.
Just one other teaching point here. So this is clearly a prolactinoma with tumoral prolactin. So then the question was, why not treat with cabergoline and see what happens? Well, cabergoline won't treat hemorrhage. It'll treat a little bit of residual tumor, but it would not have really contributed to resolution of this mass. And so really, it's either watchful waiting or surgery.
Yeah, I'm gonna play a bit of the devil's advocate here, if that's the right expression in English, and say that in terms of apoplexy, we have been looking at this topic. It's the topic of one of our recent publications, and also the topic of one of the studies we're running together as a multi-center study with the team at Cedars-Sinai in LA. It's a study called PASTOR study. And in terms of, surgery versus conservative management of pituitary apoplexy. And of course, this is in overall pituitary apoplexy, not only the, specific subtype of prolactinomas. And what we've been seeing is so far, and of course, these results are to be published, is that, the hormonal outcome, as Dr. Stenson mentioned, really seems to be similar. We haven't seen any differences in terms of timing of surgery, and the timing of surgery being divided in 72 hours and after 72 hours. And I think though the point that in my mind it's an important one is the issue of doing surgery versus not doing surgery here. Overall, not specifically in prolactinomas, considering what we see here, that in our personal data, we found about 87% of pituitary apoplexy to have a decreasing size spontaneously if we follow them up, and over about 50% can have a complete shrinkage of the tumor, so we can avoid surgery. In my mind, actually, the consideration that I have is when we have diplopia, third nerve palsy, and if those patients would improve even without surgery, which we, and many people still would consider to do surgery. So just to bring some additional points for discussion, I think many of those questions are unanswered, and I think are important for future discussion. But as Dr. Sansa mentioned very well, this is a prolactinoma, and that brings additional points for discussion here. Because as Henry will show, there was a still prolactin elevation after, at the point in February, as I think he's going to show in the next slide.
Dr. Simpson, just a quick question. You mentioned the use of cabergoline as a trial to see whether or not there would be a response. But I think there has been a shift towards surgery versus cabergoline, even for prolactinomas. I just wondered if you could comment on that for the particular case of apoplexy, if that changes anything, or if you still think in this circumstance, surgery is already winning out versus cabergoline.
So I did not start a trial of cabergoline. It would have normalized the prolactin most likely, but it probably wouldn't have had a lot of impact on the mass of the tumor. I'm a big advocate for prolactinoma surgery in the right patients, and had the pleasure in January of being on a international consensus panel about this. And I will say there's more to come and how people are feeling more positive about first-line surgery in a subset of patients. So you're right, we are shifting the paradigm.
I was going to say, Susan, that I was just actually use my example. So I traveled to many countries, as you know, through our foundation, and the rest of the world don't have the luxury of what we have right here. Can you tell the team right here how much is cabergoline expense a month on average, so that way they understand how it would be prohibited in places like Mexico, Peru, Ecuador, Panama, in other parts of the world, so that way they get a sense, because that's what they do. They do surgery for these cases because and especially now with the endonasal approach, a lot of these fellows who are doing surgery around the world, they have come to the United States, trained the way we do the surgery, and then they take it back. So they buy $100,000 of equipment and they get to do, many of these surgeries.
Right. So the cost of cabergoline for a regular dose, a non-resistant tumor, would be at 0.5 twice a week, is approximately $400 a month here in the US. Bromocriptine may be somewhat cheaper, but it is really, in a lot of patients cannot tolerate the adverse effects from bromocriptine. So it's a challenge.
If I may just quickly say something, just having spent 10 years in Europe and having seen how it's done in Germany, France, and Switzerland, even if the patient has loss of vision or ophthalmoplegia, prolactinomas are universally treated medically first, because the medications are much cheaper. And I have seen gigantic prolactinomas with loss of vision that are very quickly treated medically rather than surgically. I mean, that's just the other side of the world. It's a different environment. The medication prices are capped, and it's a different experience. I know that here will be different because also the different circumstances.
This is so great, Misha, to have all. This is why it's so amazing that this morning we have, as Andrea said, over 60 participants from 12 different countries. So you get to see the diversity of ideas, thoughts, and ways of doing things around the world. And I think that this is what this experience is so rich. So to be respectful of the time, let's keep going so that way we can get to another case also to illustrate some other points.
Yes. So here, yes, some scenes that I can skip because it was discussed already. So this is the CT that we got also as part of the study that we performed.
I think the CT is important just to illustrate, and I don't know if Olumu or Angela Downson. Are you, Angela, you on the line? Or Dr. Olumu, are you on the line, Noma? Or ENT colleagues? But this is to illustrate as they get a sense as to what the bone work they're going to need to do. They get some of the septations. They understand what some of the septations are going to the carotid or not. Is the bone thin? Are the septums deviated? So they look at a lot of important anatomy. You know, maybe we can illustrate this anatomy when we see the video, JP, so that way we can move on.
Yep. So let's go. So this is the differential. Actually, it was pretty clear that it was a pituitary adenoma, but we just had some cystic lesions as well. In this management, as we discussed before, options here, we already were discussing these points. And actually something important is the patient was really interested on surgery. He was really concerned about side effects from the medication, etc. And this is the video of the surgery. Here.
And Henry, it's okay. So basically here you're gonna see that in this video, we of course had the, in my opinion, the ultimate goal of achieving disease control with surgery and surgery only, since we decided to go for surgery. So you can play the video. And here, basically, the first part is, you know, our ENT team working with, you know, the first part that was done here was the correction of a septal deviation, so we could work. And Henry, maybe let's skip it a bit since our colleagues are not here for the sake of time as well. But here you see that the sphenoid sinus face is being open, and after that is completed, we're gonna be maximizing the opening of the face, the sphenoid. So we need to have all of that completed. And here, that's okay, you can just leave it there for now, just let it play. We open the posterior wall of the sphenoid sinus, and we are exposing as much as possible all the way to the medial wall of the cavernous sinus on both sides, and all the way to the superior intercavernous sinus. So at the transition of the cella and with the suprasellar space. And what you see on both sides is, stop the video. What you see on both sides here, this is the clinoid segment of the carotid. This is the clinoid segment of the carotid. This here is going to be the optic canal. This here is going to be the optic canal. What you see right here, this is the lateral optic carotid recess on this side and this side. And of course, this is the tumor we're dealing here. This part was not illustrated, but this tumor had no clival recess. This was all bone. So we had to drill all this area, and you saw that we skeletonized all this area and this area, so we could clearly see the medial walls of the cavernous sinus. We knew the pituitary gland was shifted up in this case, so we had to find the gland, but we also had to clean the medial wall because we wanted to leave no tumor, no single piece of tumor behind. So let's go ahead. So you see here the dura of the cell is open. We find a plane, we cut the dura around the pituitary gland, carefully preserving that plane, and you can already see some necrotic tissue here in this area. So we continue dissecting, and then we're gonna go and work around all the way until we can kind of like doing this thing of removing the dura of the anterior wall of the cella. And with that, we can see the tumor and the separation between the tumor itself and the dura. Once that's completed, the first part is to identify the gland. And you can see that we were able to identify the gland right here. And with that, we're gonna separate the rest of the tumor. Why is it important to find the gland first? So we can preserve the gland. So we wanna minimize any dissection around the gland, so we minimize the chances of pituitary dysfunction, especially in a patient that already had some pituitary dysfunction. His gland is very, let's say, friable and susceptible to new deficits. So we see a lot of necrotic tissue. We remove that tissue, we clean that tissue to the best of our abilities by suction technique. And you see preserving the plane between the gland and the tumor capsule using this round knife. And then we can go ahead and start mobilizing that tumor away. You see trying to use the pseudocapsule plane here and being able to mobilize that away from the medial wall of the cavernous sinus on the right side. And then once that's done,
I was going to say, JP, maybe illustrate right there. That sounds like he just glanced through that in a matter of 2 seconds, but that's such a dangerous part of the procedure. You just saw in the picture that he showed the carotid on that side. you know, and to talk about the different segments of the carotid. So he had to disconnect that whole tumor from all the different aspects of the carotid. And that obviously is very, very, he did already on the right side of the patient. Now we're about to move to the left side of the patient, all right, where it's going to be a little bit more welded, but something extraordinarily dangerous that just happened right there. But it just seems to be so routine because you guys get to see these films all the time. But keep going, JP.
Sure. So here you see, like, we're trying to, work pseudocapsular, I'm sorry. And here just removing that tumor, and you see that we found this plane with the normal gland, and then we're transecting here. Likely some part of the normal gland came on this area here as well. And then that tumor, the growth of the tumor is going to go. And after we do that, then you're going to see that we're going to inspect the left medial wall of the cavernous sinus. And you see here, like, we're just peeling that growth of the tumor. So you can just remove the tumor here. Yeah. Here you can skip to the part after the tumor is removed.
A quick question. How do you know it's a normal gland? I mean,
just stop the video for a second, Harry.
Yep.
So that's a very good question. Basically, at this part, it's not well illustrated because we don't have it right here. It's the gland is here in the top. But basically, there are, I would say, three ways. One is the consistency of the gland that usually is firm compared to the most soft type of tumor. Two, the color, which is more orange-like rather than the usual whitish type of pituitary tumor. And three, if you go very close to the gland, you're going to see some capillary vascularization that are verticalized in nature. So using all those details, one can, predict that. Of course, to me, to us, the most important point is going to be the preoperative identification, the MRI scan, which helps us to define that pseudoplane and to be able to mobilize the gland. The anterior gland is easy to be identified. The posterior gland is more whitish in tissue, and that's where it's good to avoid bisection techniques. So you avoid sucking the posterior gland with the dissection. So that's where I usually like to go with a straight dissector to do that. But let's keep playing for the sake of time because we also have the second case. And you see what's happening here? This is the interesting part. So there is this residual tumor that is very adherent to the medial wall. We didn't want to kind of like, we just wanted to clean that tumor. We didn't want to push much more. But we were trying and we were trying, and I couldn't remove that tumor from the medial wall. It was very adherent to that medial wall. So we decided at that point, and here's just to illustrate, you see the diaphragm here, the normal gland tissue is here and here, just trying to dissect the tumor away from the medial wall and just couldn't. So we decided at that point, okay, we want to get a gross total resection. We're going to remove the medial wall, the cavernous sinus. So to do that, we went ahead, we drilled this inferior lateral component of the sella, so to expose not only the clinoid segment of the carotid, but also the anterior wall of the cavernous sinus, which is located here. So by doing that, what we did is we Doppler the location of the carotid, more specifically the location of the vertical segment of the carotid, where it's going to join with the clinoid carotid here. And then we cut this dura. So the bottom part had been cut, and here we are just cutting and transecting right medial to that. You're going to see what's going to happen then.
And I remember when JP and I doing this, he's telling me, when I did this with Gentili, he never let me go because he says, JP, one day you're going to do this yourself. Today, you're not doing it with me because this is very, as you can see, he just spit it out like it's a nothing, but this is a very scary move. But, you got to be ready. And you'll see, we have gotten into the cavernous sinus, which is what is going to happen right now. But so you just got to know how to control it.
Yeah, so here you see that now we found this capsule here, which is the medial wall. And once we got to that point, honestly, like you relax. So what you see here now is just cutting the dura of the floor of the sella. And what you're going to see, we're going to peel this and we're going to start to see this structure, this bony structure, which is the posterior clinoid. And then we're going to remove the medial wall of the cavernous sinus. And you see just mobilizing the tissue. And then we're going to be able to transect it in the inferior part, and there we already coagulated the inferior hypophyseal artery that was right here. And then we're going to transect here and here.
And that's going to be beautiful. That's going to give a gross total resection of this lesion. That last portion was completely welded, and we were afraid of pulling it. I already pulled it once, and I got into the carotid. So I knew if we're going to do this, it's going to have to be from medial to lateral.
JP, maybe you can mention the importance of localizing and using the bipolar in the inferior hypophyseal artery for this lesion.
I'm sorry, say it again.
The importance of stop the circulation in the inferior hypophyseal artery.
Yeah, so stop the video right there if you don't mind.
Yep.
No, in that part where you had the posterior clinoid. Okay, so we can use this one here. Like, anyways, you see here, this is the posterior clinoid here. So what happened to do this maneuver? At least there are two ways to open this and to open the cavernous sinus and to get a safe resection of the medial wall, in my opinion. The one is to go through the anterior wall of the cavernous sinus, which is what we did here. So expose the anterior wall of the cavernous sinus, map the carotid, which was here, create a cut and dissect it from lateral to medial, cutting the superior attachment, basal attachment, medial attachment, and then removing all of this. When you are removing the inferior medial attachment, you have two structures, the inferior hypophyseal artery, which is going to run in front of the base of the posterior clinoid, and you're going to have some ligaments that Juan named the inferior paracellular ligaments, which is a pretty good name. After you do that, you can go all the way to the posterior clinoid. So a removal of the medial cavernous sinus wall should expose the posterior clinoid process. The other technique is if you go through the inferior intercavernous sinus and you just open from medial to lateral with a feather blade. This one, you can do it as well. Usually the tumor will take you there in this direction, but the problem is that I usually don't have as good as control as when you go through the anterior wall. So I favor the anterior wall technique as one proposed. And that's it. So the inferior hypophyseal artery in the posterior genital of the carotid arising from the meningo hypophyseal trunk will run in this direction. You got to know that. So you got to coagulate it here and transect it. Don't pull anything, as Dr. Quinones mentioned, coagulate it and transect it. So if you're not comfortable with sharp dissection, and by the way, I would say nobody starting this, don't try this at home, as Ricardo mentioned. This is definitely, I consider this as advanced craniopharyngeal endoscopic resection. So you got to do a few cases before you do this one.
Thank you.
Beautiful. Keep going for the interest of time and show that last portion so that way we can wrap it up. And then the reconstruction was done beautifully. You can see right there, and then Dr. Donaldson, I think, put all the anatomy back in place, and most likely this patient went home the next day. We'll see. So let's see what we have with the hormones and the pathology.
Yes. So the post-op was a gross total resection.
And this is where, Susan, I think that we can reconsider whether or not we need to get postoperative MRIs from these patients. I know that we're, usually endoscopically, there was nothing that we could see. So maybe we can skip in the future the postoperative MRIs in selective cases and stuff like that.
It's great for teaching, though.
Yes.
So this is, I don't know if Dr. Yentas is here.
He had a family emergency, but,
Yes. Some representative slides about.
Before you proceed, I see Fernando has a question right there. Fernando, Dr. Hakim, please.
Good morning, Dr. Q. Good morning, everyone. Just a short question. Are you doing post-op MRI? How many days after surgery? Or months or weeks or the next day?
This is great. That's this question mainly for Dr. Sampson. She's implemented a protocol. She wants to get these patients home the next day in the morning, and ideally probably in the future the same day out of the hospital. But Susan, can you tell Dr. Hakim, what your protocol is and what you advocate?
Well, I mean, in terms of the MRI post-op, I think here we've been doing them on post-op day 1, although that protocol may change in the future, and then at 3 months again. But we do want to make sure that we're monitoring the patient closely, even if they're discharged. And also we do a post-op fluid restriction from day 4 to 8, where we're communicating with the patient to avoid hyponatremia.
And Fernando, the only reason why we can do this, Dr. Sampson calls these patients with her team post-op day number 1, she sends them out, post-op day number 2, she keeps checking, as she said just right now, and we have had almost no returns to the ER or no readmissions since she joined our faculty not long ago. And so we've been very lucky with that, but that's how so the protocol is usually post-op day number 1 for the MRI, although that may change, and then a few about 3 months after surgery.
May I interrupt quickly here? As a neuroradiologist, I find these post-op exams extremely helpful when they come for follow-up subsequently. Sometimes it's very hard to tell what is recurrent tumor from post-op change. And the immediate post-op exam tells us what is post-op change, and that eventually helps us compare with the follow-up exams. So that's my experience, at least.
Thank you, Prasanna. And then there's a question from Dr. Vargas right there. JP, the risk of carotid injury.
Yeah, that's absolutely a fantastic question. I think that well, on the cases I've done, thanks God, I have never had a carotid injury, including those cases. I did have in a medial wall resection once. I did have injury to the inferior hypophyseal artery that we controlled with bipolar coagulation, but it bleeds quite a lot. I have to say, it's a bit scary when you get there. And the recommendations are the following: bone exposure. I think we talk maybe not enough about the importance of skull-based exposure, and it is 70% at least of the surgery. Number 2 is adequate exposure of that dura in the inferior lateral segment of the gland. We have the misconception in many of us that the cavernous sinus is just right lateral to the gland. It is not. It is actually mostly inferior lateral to the gland, especially that anterior pocket or that anterior space of the cavernous sinus. So once you have that space exposed properly, you would have to map with your Doppler. So the Doppler becomes the most important instrument. If you have to choose between a Doppler and a navigation, always choose a Doppler, always. And with that Doppler, you can map your carotid and then go ahead with the opening. To open the anterior wall of the cavernous sinus, you can use a sickle knife, or you can even use a straight scissor. But after you do that, I would definitely recommend to have one kind of like McAlvin type of knife dissector that will allow it to cut the ligaments from back to front without the need to go and work with the scissors. I just find the scissors sometimes a bit risky depending on the angle of the carotid. But the other and most important point is correct control of the venous bleeding, so you can properly see and identify the carotid. The cavernous sinus will be bleeding some venous blood, and you got to be very comfortable with the packing of the venous bleeding from the sinus. So a small opening, it starts bleeding a lot, and then you tend to try to control that. You're not going to be successful. The packing will not reach the calf sinus. So you got to open that a bit more, and then you can pack the sinus. Control the bleeding, and then continue the dissection. And I believe those would be in my opinion, at least, the most important points to proceed successfully.
And the other one, I know we showed a video a couple of weeks ago, one where the tumor had already done that dissection in that plane in the anterior inferior lateral aspect. And we thought the tumor was in the cella. It turned out that it was in the cavernous sinus, and it had already created a pocket. So we ended up opening. And I know that we showed that video as well. But beautiful and very dangerous maneuvers, obviously, but very appreciated by everybody. Keep going, Henry. Let's see if we can.
Yes, we have the labs, close-up labs.
Mm-hmm.
Dr. Schules is here.
Sorry, I muted myself. The prolactin dropped on post-op day 1 to 2.4 and then 0.8 on post-op day 8. And then he did have one episode of DI before he was discharged. So he was given DDAVP once, but then he didn't need it throughout his time at home, and his sodium after fluid restriction looked like it was 144. So he was released from fluid restriction. He's on thyroid hormone replacement. I forgot to mention, after all of the panhypopituitarism, he was put on thyroid hormone replacement and steroid replacement as well. And then this is his labs, his testosterone labs after being off of everything for some time now. And so he has follow-up set up, but it looks like he's panhypopit at the moment.
Thank you, Dr. Schules.
Amazing. Congratulations. Beautiful result. Multidisciplinary approach. Lots of people.
Yep.
Maybe let's move to the second case then.
Thank you, Henry.